We'd like to welcome you to today's webinar resident series, Successful Impression Techniques. It is being presented by Tremaine Watkins, CDT, Clinical Director of Guided Surgery Implant Solutions. And now it is my pleasure to introduce Mr. Adam Dreyfus, Director of University, Government, and Institutions. Take it away, Adam.
Oh, good morning, Jessica. Thank you so much for that warm welcome. And Mr. Adam Dreyfus, wow, I don't deserve those accolades by any means. But I do want to say before we start, happy and a healthy new year to every one of you. And from the bottom of my heart, thank you. Thank you for an amazing 2022. We didn't know what that year was going to look like, and it turned out to be a phenomenal year. The programs that you're all involved in have continued to evolve, and so does NDX when it comes to supporting you. Please know that we're here for you today, tomorrow, and for the future. I am just so excited for what 2023 is going to bring, and I look forward to bringing it to you. If you have any suggestions, feedback, when I'm in your clinics or not in your clinic, please reach out. Let me know what your feedback is. We do this for you every single month. Because we just can't wait to share the knowledge base that we have. I'm not your knowledge base guy, but we do have one of them on this call today. Without further ado, I'd like to introduce Tremaine Watkins, who, as I've said in previous with other speakers, Tremaine is an encyclopedia. So I have to tell you, reach out, ask questions. But without further ado, Tremaine Watkins, please take it away.
Hi, everybody. Thanks for attending. I have a little bit of a cold, so I'm sorry my voice is a little weird, but we'll get through it. So today we're going to talk about taking physical impressions. We're going to talk a little bit about materials. I love history. There'll be a little history in there. And then we'll talk about techniques, potential problems, go over a little bit about removables, implants, and full arch cases if we have some time. So let's get going. So beeswax was the first impression materials. I'm sure you guys probably know. It seemed to crop up in Paris in the 1750s, and by 1787, we have an advertisement from New York of a dentist who was taking impressions with beeswax. The first really modern impression material that we still sometimes use in the lab is reversible hydrocolloid, and those came out in the 30s. And by 1947, we were actually seeing what we use as modern alginate today. What's interesting is at that time, alginates were used for master impressions for fixed and things like that. So don't do that today. We have so much better impression material, but we'll talk about that. So we started seeing some polysulfides and condensation cured silicones at this time. They're good materials, and a lot of the putties that we use in the dental office and the dental lab are actually condensation cured silicones. But again, pretty good, but not as stable as modern materials. So in 1965, polyethers came out. Polyethers are that, as you guys know, that purple stuff that you put in that 3M makes, comes in that big dispenser. And they were revolutionary in their day. They have really good mechanical strength, good elastic recovery. They're hydrophilic, no shrinkage, flow well. And it really, that I would say is the beginning of modern, especially fixed impression taking. And then we get vinyl polysiloxanes, which we use today. One of the cool things about them, as you guys know, is that they use a platinum catalyst in them. So what that means is that there is literally no dimensional change from what you dispense and when it's set. And that's what makes it unique, is that it is so accurate. It's intrinsically hydrophobic, but sometimes surfactants are added to help with that a little bit. They have extremely high dimensional stability, resistance to change, extreme temperatures, and they have really nice elastic recoveries. You guys know practically all the impressions that we're taking are VPS these days. So somebody said, well, polyethers are hydrophilic and VPSs are stable, what if we put them together into vinyl polyether silicone? And that was a material that developed in 2009. I believe there's only one vendor right now. And it's interesting because it seems like it would be the perfect material, and it sounds like it works pretty well, but it's not as revolutionary as we thought. Now, you guys learned about digital last week. We'll talk about that a little bit, but I think we may not see as many advances in this just because we're well in the midst of the digital impression revolution, in my opinion. You guys are probably wondering, why in the world are we talking about physical impressions in 2023? Can't we do everything digitally? You know, I feel like a big part of, for me, learning new things and stuff is I want to have a lot of tools in my toolbox, especially, you know, in more straightforward situations. Sometimes it doesn't matter, but when I'm dealing with situations that are really difficult, it's nice to have a variety of options that I can use. And so I think going forward, physical impressions are still going to be a tool in our toolbox, even if iOS is our primary tool. There's a few situations where a physical impression can be really helpful. If we're getting a lot of fluid pooling in a subgingival margin, as you guys know, if you scan fluid with an iOS, the iOS says that the fluid is the surface of the prep, so it's going to give you an open margin 10 times out of 10. Especially if you use a hydrophilic material, you can actually use the impression to displace some of those fluids with a physical impression, which can be kind of helpful. Removable cases. We're right on the cusp of, I feel like, digital removables. If you can hold the cheek steady and get the vestibule where it needs to be, the current generation of scanners can definitely capture mucostatic digital impression. But sometimes it's a little bit difficult to use. Sometimes we have a little bit older scanners that just get lost reading tissue. And when you use a proper technique, and we'll talk about that, a physical impression can give you a nice mucostatic impression, so that way your removable prosthetics fit better. And all-on-X cases, I think, are another good example. There are some iOS systems with specific techniques that can give good cross-arch accuracy. Probably some of you guys are familiar with photogrammetry, another digital solution. And I think we're seeing some more evolution in that area right now. But we know for sure that an open tray PVS or polyether taken properly gives us a very, very accurate cross-arch. As a matter of fact, when they're testing iOSs, they use a physical impression as the standard. All right, so let's talk about like general rules. Like if you're just looking at an impression, how do you know if it's a good impression? Like this here is a good example of an impression. Got a couple of there. So the mix is really, really, really important. One of the most frustrating things I feel about physical impressions is that it's possible to get an impression like this. In other words, it looks really good, details good, everything's good, and the prosthetic that's made on it doesn't fit. You're like, well, why is that? It's a good impression. Well, maybe the patient bit on the tray, as we see here with this little bit of peak air exposed. We'll talk about this in a minute, some of these challenges, but we want to minimize all the problems that can make an impression look good, but not be dimensionally accurate. So as you know, most of us are going to be using auto mix materials today. So the main thing is when we're dispensing the material, we want to dispense a little bit onto a paper towel or something before we start filling the tray, just to make sure we get the right thing. We also want to make sure if we're using four-handed dentistry, like a heavy body and a light body, that we use the same manufacturer's materials, the same setting rate, and that we start them at the same time. So when your assistant's loading the tray and you're syringing around the prep, make sure you guys start at the same time to give good adaptation. Impression trays. Impression trays, as you guys know, are the foundation of our impression. So we need to make sure it fits well. We don't want it to be too big because then there'll be too much impression material that may be dimensionally inaccurate. But if the tray is too small, we can get tray contact. And that's really, really, really important to avoid tray contact, because what happens is, especially with a triple tray, when the patient bites down on a plastic tray, if they're pushing on the edge of it, they actually flex the tray a little bit while the impression material is setting. So then when you remove the tray from the mouth, you often can't see it, but the tray springs back and compresses the impression, which has the effect of making the die smaller than the tooth. And you get one of those crowns that goes down like 80% and just won't go the rest of the way. We'll talk about this quite a bit in our troubleshooting, but we need to make sure we capture necessary details. Check impressions under magnification just to make sure everything looks really good. And then adaptation. We need to make sure that we're well adapted to the tray, that there's no gaps between the tray and the material. We want to make sure that the wash is seamlessly adapted to the base. We want to make sure that, that we're well adapted to the teeth and the proximals and all those different areas. The better impression we get, obviously, the better results we're going to get. So we're going to start talking about crown and bridge impressions, since you probably do more of those than anything else, then we'll kind of work with some of the other products. So we talked about impression tray again, that it's really, really important to select the right tray, make sure it fits, all that stuff. I love metal single-sided trays, but I know this isn't really the reality of day-to-day dentistry. That's okay. I think the main thing is making sure that the tray fits well. You know, especially if you're using a triple tray, put it in the mouth, have the patient bite down and make sure it's nice and free so that we're not hitting those borders or whatever. One other little tip is VPS. Latex is very, very bad for VPS. It prevents it from setting up. We'll talk about this in a minute, but you want to make sure you use latex-free gloves when you're using VPS, which is, of course, the majority of what we're using today. So retraction is really, really important. One of the things that is really different in a laboratory, and I'm sure you guys have done a little bit of model and die work, but you know, when you're in the mouth, yes, the tooth gets stained red a little bit, but you can look, you can say, oh, look, there's the tooth. It's whitish. Oh, there's the gums. They're pink. But when we get in the laboratory, the whole thing is stone colored. So if there's not a clear separation between the tissue and the tooth, we're not 100% sure we have the margin accurate. One of the things I'll tell you guys, I saw this a number of years ago and I thought it was kind of interesting. They did no cord, one cord, and two cord techniques. And they had dentists and laboratories evaluate them. And everybody liked the double cord for clarity, but they also found that there's a little bit of crestal gingival loss on that. So I would say for a lot of cases, you're going to get your best results by using a single cord, and then just making sure, remember that you only have 30 seconds once you take that baby out. So be all ready to go when you pull your retraction cord. Some of the syringeable retraction materials can work well, like Expacil, Traxident, some of that kind of stuff. Whatever retraction you use, make sure you give it enough time to work. You know, it takes a couple minutes for paste and 3 to 5 sometimes for a cord. Cords, pre-preg cords with hemostatic agents can be helpful. Again, we want to be careful not to handle the cord with latex gloves, or it can cause the impression material right down by the margin not to set up. Fluid control is really, really important. Of course, if you use a hydrophilic material, that helps a little bit, but you want to make sure you mechanically dry the sulcus and control bleeding before taking the pressure. So most of you guys are probably using a four-handed heavy body, light body technique. Like we talked about, it's really important to use the same manufacturer, the same set rate, the same kind of material. So if you're using Bob and Fred's fast set impression material for your light body, make sure you use Bob and Fred heavy body. So that way they set up at exactly the same time. A lot of offices that do this and want to make it predictable will kind of count 3, 2, 1, go. And then the assistant will start loading the tray at the exact same time the dentist starts syringing around the prep. One little tip that you can find is, of course, you want to syringe into the sulcus and over the whole body of the prep on the axial walls, the contacts, and then a little bit in the central dissectional groove, makes your impression better. But take your air hose and blow that impression material down just gently onto the prep. It gives you a little better adaptation, and it can help get that last little bit of detail that makes the impression so nice. If you blow through it, you can always put just a little bit more on there. And then it's important, I love this timer. When I was a kid, we actually used these. I mean, I'm sure everyone's using their iPhones and stuff like that now, but if it's a 4-minute set, make sure you give it 4 minutes. You also, we'll talk about this a little bit when we're troubleshooting, but it's important to, control your office temperature, because if it gets too hot or too cold in the office or where you're storing the impression material, it changes the setting time, which can mess you up if you're 4 minutes and you're in a really cold environment. You take it out, you're like, well, I waited 4 minutes, but it didn't work very well. It's nice to have some good tricks for patients that are gathered. Sometimes an IOS is the trick, which can be nice. But I saw some funny articles about telling the patients to wiggle their toes while they're taking the impression, or talk to them, or give them a movie or something. For some people, it is all physiological and you just can't stop them. But for many people, if you can take their mind off their troubles for a few minutes, they can kind of get through it. Another tip I've heard is kind of have them sit up and lean forward a little bit. That can help with the gag reflex as well. Now, us laboratories, if you ask us, what do you want? We're going to say we want a full arch impression. Because if we have a full arch impression, we know we have all the teeth so we can get the best possible bite. We know that we have the contralateral teeth, which helps us with contour. So it's like if we're doing number 14, we usually are like, well, if it looked like number 3, that'd be a good thing. So that's really helpful. But again, the reality of things is most of the time we're using quadrant triple trays, and that's okay. The main thing you have to do is you have to look at the situation and say, are there enough teeth in the impression that I'm capturing to have a stable bite? I'll give you an example. If you're doing number 12 and there are no posterior teeth on that side, I would recommend a full arch impression, because hand articulating that or getting that bite set, it's just not going to be stable, and it's going to lead to more occlusal adjustment for you. But on the other hand, if you're doing number 12 and you have 14 and 11 and 10 on your impression, it'll be fine. It'll be nice and stable. So that's really important. So it's kind of funny because for impressions, I'm like, okay, I need a big impression. But for bites, we want a nice small bite. If you look at the bites that you get back from your laboratory, most of the time you'll probably notice that they're trimmed down to just a little segment that sits on the prep. And that's because a lot of times, either with the impression or pouring or whatever, we don't have the details of the proximals of the teeth as exactly the same as the mouth. So if we use a large bite, it actually prevents the models from fitting together. So we'll trim the bite down so that it makes sure that we get the exact right space over the prep, but then we'll be able to see how the other teeth fit together. It also gives us an opportunity to evaluate the bite and make sure we think it makes sense. So let's talk about some of the problems that you can run into when you're doing your impressions. So the first one is tray contact, and we talked about this a little bit. So what this means on a triple tray like this is when the person bit down, they were applying force in these two areas that have the little circular marks on it. With this kind of tray, I would say it's a near certainty that they flex the tray on this. You can look at it and make your own judgment, but if you think they've been loading the tray, I would recommend taking a new impression, because again, this is one of those situations where the tray was flexed when the material was setting, it'll spring back and it can lead to inaccuracy. The other thing you may want to look at is gauze. If there's a lot of burn through on the gauze, when we try to pour a model, the gauze just destroys the incisal edges of the model. So it winds up pretty hard to get a good articulation. So if you're seeing a lot of burn through from the gauze, maybe have the patient not bite down quite so hard the next time. And in both situations, I would recommend taking a new impression. Now, every once in a while, let's say you're using my metal single-sided tray, you get a little bit of tray contact. If you were holding the tray in with your hand, you know you weren't putting enough force on that to flex the metal tray. So I would say kind of who cares with that. So really what you have to decide when you're looking at your impressions is, did the patient flex the tray or not? And if they did, I would consider taking another impression. Now we have a few different scenarios where the margin looks weird. And see with this one, how it looks kind of blobby. You know, you look to the left side of the screen, you can see a nice crisp margin, and this is kind of gone. So there's a few things that can cause that. Usually what it's caused by is that the impression material couldn't get all the way down to the margin. So it could have been that the sulcus was full of fluid, which prevented it from flowing down. It could be that we didn't get our light body material down in there, or it could be that when we were putting our tray on, it didn't kind of smush the material down there. That's my technical term. And last but not least, you could have a weak material that ripped. So in other words, it got past the margin and down onto the axial wall of the tooth. And when you remove the material, it tore the material that is below the margin, but also a little bit of the margin itself. With all of these, again, really good idea to look at this with your magnification. If the margin is captured perfectly and it looks a little bit ragged, kind of who cares? But usually with these, you're going to be missing some margin and you'll probably want to take another impression. So next thing is voids. So whereas the other one is often caused by, it can sometimes be caused by fluid, but it's more likely caused by tearing. This is almost always caused by the material not flowing to the sulcus. So these look smooth, not raggedy. And while there could be some fluid in there, oftentimes it can be caused by your material setting up too fast, maybe accidentally syringing a little bit of air into the sulcus. So if you get a situation like this, you really should retake the impression, because don't forget, your laboratory will make your restoration, we're talking fixed cases here right now, to the margin that they see. So this crown will extend to this margin, and so when you put it in the mouth, it'll be short. It'll be missing that last little bit. So this is like big tears. This isn't that little fine tear like we're talking about. These are big tears. A lot of times these can be caused by contamination, like we talked about latex getting on the prep, or latex on the retraction cord, or maybe some kind of acidic retraction material or hemostasis material, or if you had a core buildup or provisional, the acrylic can mess it up. And sometimes if we pull the impression a little bit too soon, can also cause this. So usually when you see this, it's caused, something is preventing the impression material from setting up. Impression voids. I don't know about you guys, but probably out of all of the things that I see in the laboratory, I see more of these than anything else. And there's a few different causes. One is if the tray is not filled all the way. So if the tray isn't filled enough, when we push it down, it won't force that impression material around the teeth, and sometimes we get voids like that. The other thing is it could have to do with setting. So if I load the tray too late and the impression material's already started to set, it can lead to this problem. Or what we've seen a lot is if the tray is moved. So once you position the tray, you want it to sit there. Don't move it while it's setting, or you'll get these flow lines. You have to kind of evaluate this. If you have one of these in the prep, of course, you're going to take a new impression. But if it's in an area that doesn't really matter, it doesn't affect the aesthetics of the case, it doesn't affect the bite, it might be fine. Your laboratory can trim that a little bit. So it kind of depends on where the void is. This, on the other hand, is a huge problem. You should always retake these impressions. And there's a few different things that can cause this. And I have one little hobby horse that I'm going to work on a little bit. If we use mismatched materials, or we don't do the timing properly or something like that, that can lead to this delamination. They want to make sure you use the same thing. The other thing I've heard of is it's called the H&H technique. And so what would be done in the past is that a dentist would take an impression with a medium body or a heavy body used to make the provisional. Then when the prep was all done, reline that and push it down in the mouth. This can happen with that because the materials sometimes don't bond to each other because they set at two different times. The other thing is that theoretically, there's really no way to get the perfect amount of material in there. You're either going to have too much or too little. If you have too little, you're not going to capture the impression. So most of us tend to err towards having a little bit too much. Well, when you push that impression down, eventually it's going to reach the point where it seals. And especially if the patient's biting on it, the occlusal force can actually balloon the impression material a little bit while while the light body material is setting. So you take it out of the mouth, it springs back. And again, you wind up with that same problem we talked about where the die is a little bit smaller than the actual tooth and the crown doesn't seat all the way. If you have to do this technique for whatever reason, you could bore holes through the material to give up pressure relief, but I would not use that method routinely. I've seen a few situations where labs can compensate for it, but it usually involves more blockout or whatever. It doesn't seem to give us the accuracy that we want. If you see this problem, for sure, we take the impression because the whole impression is bad. And then your impression material not set up. But we talked about this before. It could be contamination by latex or other things like we talked about. Could be an expired impression material. It could be that we didn't express a little bit of extra material before we got going on our impression. Or it could be that the material is a little bit cold, like we talked about, and it's not setting up all the way. Of course, we could have moved it prematurely. If you get this, please retake the impression, guaranteed to be wrong. All right, so we've kind of talked about some techniques for doing fixed cases. So now let's talk a little bit about removables. As you're looking at your removable impressions, if you see problems with them, you can use kind of the same troubleshooting technique. So, excuse me. I'm not going to go through all that again, but we'll kind of talk about some techniques. So the first thing we want to keep in mind with our full denture impressions especially is that we want a mucostatic impression. If you think about it, your laboratory is going to do everything they can to make the prosthetic fit perfectly on the model. If the impression is depressing the tissue and your lab gets perfect adaptation, then the final prosthetic will also just depress the tissue, which can lead to all kinds of not good things like sore spots and the like. So there's a couple of advantages to border molding, but one of them is that it gives a nice stable area to support that impression. So when we take the rest of the impression, we're just resting on the tissue. So anyhow, when you want to do your border molding, you can use a custom tray or a stock tray. You want to be a couple millimeters short of the vestibule, and then paint your impression material on there, squirt a heavy body on there, and put the impression tray in there just like this, where you're only capturing the borders, have the person go through their, pucker their lips, do the Duchenne smile, move the jaw side to side. If it's the mandible, make sure they stick their tongue out and move it side to side. That'll shape the vestibule so that way we know that we're getting, when we pour the model in the laboratory, we'll know those borders are where we should extend our denture. So once you've gotten this done, you'll go ahead and paint this whole area with your impression adhesive, put your medium body or light body in there, put the impression back in, and have the person go through their border molding movements again. And again, the reason you're doing that is so that you can, so that we're getting a nice passive impression so that when our new prosthetic seats, it seats nice and passive for you too. So we're looking at our denture impressions and we're trying to say, hey, is this a good impression or not so much? So we want it to be smooth. We shouldn't see any discontinuities in there. We want to see nice, well-defined peripheral borders, and we want to see the correct extension. We shouldn't see a lot of tray burn through. I mean, if you have a little bit, and especially if you're holding it by hand, that should be okay. Again, did the patient flex the tray or not is the question. And we want to see no voids, drags, tears, whatever. We want to make sure we have a nice continuous impression. If you're doing impressions for partial dentures, if you think about it, a partial denture is like a bridge that fits the whole mouth. So we need a really, really nice impression. One of the things, this is a custom tray, and one of the things I want to talk about with this is the advantages to custom trays. So especially with a partial, in all the edentulous areas, the top of the surface that we're impressing, the tissue, will be much lower than the teeth. So if we use a stock tray, we're going to wind up with really thick impression material in the saddles, which could lead to some inaccuracies there. If you want to use a stock tray, one of the things you can do is put a little putty, like in this case, you can put putty in the 3 edentulous areas, seat it in there, Let that set up and then go ahead and take your master impression, because that way the putty helps kind of customize the tray, if you will. Another thing to keep in mind, as you guys know, is a lot of patients who wear partials are going to have some pretty significant undercuts. And the undercuts we need, make sure you don't block those out. But if there's some like proximal undercuts or something like that that we're not going to use for the partial, put a little ortho wax in there to make sure your impression will come out. PDS is great for these. This is a polyether, obviously, and that's fine too. But the nice thing about PDS is it's a little bit more flexible and it has really good tear resistance. So that way it's not going to get messed up when you're thinking out of the mouth. Now, one thing to keep in mind is this is a tooth-borne partial, so we don't have to worry as much about over depressing the tissues, I would say. But if you're doing a Kennedy class 1 type case, you may want to do some border molding in the posterior region just to make sure that your partial is mucostatic for you. All right, so your partial, this one here is a good example of what not to do. You can see that the impression material isn't well supported. It's not well adapted to the tray. We have some voids. All these things are not good. We really want to evaluate, especially all the areas where we're going to be engaging the teeth. So any areas where we prepared rests, any of our guide planes, clasps, saddles, we need this to be really accurate in those areas. Again, those of you who've worked with, chrome cobalt is extremely unforgiving, but even with the newer flexible materials that we'll talk about in another presentation, they need to fit well so that we can, in the laboratory, we can control the undercut to get the right amount of retention for you. So in some ways, partial impressions are going to be some of your most challenging, because essentially you've got to get crown and bridge level accuracy for a whole arch. All right, so this is the picture I had, and it's probably a little bit of overkill because we don't have to worry about all this stuff. But what I kind of wanted to talk about is, if you're doing a denture impression, what do you really need for your laboratory so your lab can get a good result? This would also apply to free-in cases and the like. And so let's talk about this for a minute. We need to make sure we capture the tuberosities and the hamular notches. We want to make sure that we have a good capture of the vestibule and any frena that are there. We'll want a nice capture of the palate. And a lot of times when you look at your impression, if it came out really nice, you can actually see the midline suture and the details of the rugae. And that's just kind of a good way of telling what's going on. It's nice if you capture the fovea palatina, but we like those more because they show us where the vibrating line is. One thing that's easy to see in the mouth and not so easy to see in the model is the vibrating line. So if you take one of those little surgical markers and mark the vibrating line before you take your impression, a lot of times that will pick up in your impression. And then you can just let your lab know, hey, I marked the vibrating line on there, just in the denture border there, and we'll get a good result. So when we're looking at our mandibular impression, one of the things I'll say that you guys as clinicians can help your laboratories with is sometimes us laboratories don't realize that dentures are different than crown and bridge. A lot of times if we have like a slice margin or something like that with a crown, we're just trying to get all the way down to the depths of the tooth. And we're like, okay, well, I covered everything, so I think I got the margin. As you guys know, with dentures, because we have two basic types of tissue that's supported by bone and tissue that's supported by muscles, we want to make sure that we only cover the tissue that's supported by bone that'll be nice and stable. And first thing is you got to capture all those things for your laboratory. But then the second thing is make sure you kind of work with your laboratory. What I see in laboratories more than anything is sometimes I'll see extension past the mylohyoid ridge because it was picked up in the impression, and we don't really think about the fact with the muscle down there, it's going to either pop the denture up or create sore spots for the patient. All right, enough said about that. So let's talk about what landmarks we need. It's difficult, but we really need the retromolar pads. They're not only important for getting a stable denture base, but when we determine the plane of occlusion on a double arch case, we'll basically draw a plane from the incisal edges of 8 and 9 to the midpoint of the retromolar pad, and that becomes our plane of occlusion. So if we can see the retromolar pad, very helpful. We want to make sure that on the buccal side, we catch the all the way out to the buccal shelf, all the way out to the external oblique ridge. Again, we want to capture the vestibule and the frena. And then on the lingual side, we want to make sure we can see the mylohyoid ridge, so that way your laboratory will know where to end things. So again, especially at the try-in stage, if you notice that your laboratory is kind of overextending things, it might be, if you be kind enough, a good opportunity for you to share some of the knowledge that you have to help your laboratory do a better result for you. All right, so let's talk a little bit about taking implant impressions. So I'll tell you right now, I like open tray impressions. So I'm going to feature those first, and I'll tell you why in a minute. What I would say for single implants in 2023 is the best way to take one of these impressions is with an iOS and a scan body. And you guys learned about that last week, but I realize there are going to be times when we can't do that. So let's talk about open tray and closed tray impressions. So an open tray impression, as you can see in this picture, is where we put our impression coping on. It's designed so that it has so much retention it won't pull out of our impression. Then we have to poke a hole through the tray. And you're like, well, that's a pain in the behind. Why do we like that? And here's why. So when you see impression coping, of course, you'll take an X-ray to make sure it's fully seated. Once you capture that impression post, it'll never move. It's never coming out of that tray. So if you think about what we're trying to do, we're trying to create a model in the laboratory that has the analog in the identical position to the implant in the mouth. If that's the case, your case is going to be seamless. If there's a discrepancy between those two, it's going to be a problem. So with the open tray, you're less likely to have any discrepancies because the open tray coping is stuck in that impression. So that's really important. Sometimes you'll have a little bit of challenge with access because the open tray impression copings are a little bit taller. You'll want to, you got to find a balance too. Like in this tray, this is probably a little too much cut out. You don't want to cut out more than you absolutely need. When you're taking your impressions on these, make sure that you syringe a little bit of light body material around the open tray impression coping on some of the retentive features on the tissue, the proximals, and the central groove, and right where the implant comes out of the tissue. And then, of course, you'll have your assistant load the medium body, or I would recommend heavy body with one of these. Excuse me. And then once it's before it sets up, you'll take your cotton swab, and you have to swab the top of the tray so that you can see your impression coping. So once it sets up, you'll unscrew the screw. Make sure you send the screw to the laboratory because they got to have that. And then you'll just send in your impression, your opposing, and your bite, because the impression, the coping will be stuck in it. It can't move. So this is very, very predictable. Closed tray. We all know that these are more straightforward to do, and so it makes it a little bit easier. But here's what I'm going to say about a closed tray impression. I've been doing this a long time, and at most laboratories, the people who load the impression copings in the impression have a lot of experience, and there's only a couple of people that do it. It's not a free-for-all because it's when you realize how important this is. If it's not loaded properly, it creates those cases where the bite's way off or the rotation's way off, basically where the analog is in a very different position from the implant itself. But when you take an open tray impression, as you know, you'll syringe around it. I would kind of recommend syringing around the occlusal 2/3 of the closed tray coping with whatever material you're using in the tray itself, heavy body or medium body, to make sure we really get an accurate capture of that. But when you take the impression off, you have to take the post off and send it to your laboratory. Well, your laboratory has to clean out the impression really good if there's any damage. with when the coping came in and out, put an analog on there, and they have to see it. And I mean, obviously, you do it under magnification, you can see the features, but to a certain extent, you can't see that it's all the way down. You have to push it down. You feel it kind of snap, and you're like, I think that's good. And I don't know, any system that involves, I think it's good, I'm not crazy about. So that's why I don't like it. If you have two, like the right-hand picture here, if you have two of your impression copings that are severely angled towards each other like this, you're going to have to use an open tray technique. Because if you used a closed tray, it'll rip up the impression and it won't be any good. Two other little tips I would say if you do need to use a closed tray impression. One is if you're using multiple impression copings before you take the impression, it's kind of a nice idea to take a carbide high speed and etch the tooth number on there, on the buckle. So that way your lab knows which one goes where. They are manufactured, but they could be slightly different. So getting the one in the right spot can be very helpful. Second thing is make sure you send all the parts to your laboratory. Send the impression post, and the screw. I mean, you could say, well, why don't you get another impression post? We could, but again, it could be a little bit different than the one that you use. The most predictable way is to load it back in there. The other thing I would say, I see some dentists who put the impression coping in the impression. If you've already loaded an analog on it, that's fine. But otherwise, we're going to have to take it out again and put the analog on and put it back in again. So that creates a little extra wear and tear on your impression. So I would say it's better to just take the impression off, put the parts in a little box, and send the whole case to your laboratory that way. If you took a film on an open tray and the crown doesn't fit, there's something for sure wrong with the impression. You got to take a new impression. There really isn't because you can't have a loading error. So with a closed tray, it is possible to have a loading error. So if you want, before you take another impression, you can ask your laboratory to reload it one more time just to make sure that it's not correct. Bites are really important for implant cases. And I mean, they're really important for every case, but like with our left-hand case here, you can see trying to get an accurate bite on this case would be a real challenge. And I like this technique. So what you would do with this technique is when you had your impression copings in, you filmed them, you know they're in the right position. Before you take the master impression, go ahead and take a bite in that area that fits on the impression copings. Again, with a case like this, it's really important that you put the tooth numbers on. That'll help your laboratory. Then you take your master impression, and even if they're open trays, kind of who cares? Your laboratory can take them out of the impression once the models are made, put the bite on, and it gives you a really nice way to get an accurate bite. If you can't do this for a particular case and you were trying to restore this case, I would strongly recommend doing bite blocks or something like that. I mean, you could build up a putty if you want, but again, keep in mind that models are heavy and they're going to want to tip down towards the posterior. So it's nice to have some material stabilizing them. Concerns with impression materials, implant impressions. This is the vast majority of the problems that we see, is that the impression coping wasn't fully seated. Now, this is an old external hex, so they're easier to see than some of the newer internals. But you got to make sure that's fully seated. If there's not, there's no point in even taking it. It's funny because I would say on 80% of the cases that I've seen over the years where the crown is rotated, the problem is there's no x-ray. So it probably didn't get seated. Really, really, really important to do that. The other two problems that can happen is that the components can interfere with each other or with adjacent teeth. With an iOS, with the scan body, you cannot adjust the scan body. If it hits the adjacent tooth, you've got to pick something else. You cannot adjust it. But with physical components, you can adjust them if you want to. That's fine. As long as they're still stable in the impression, that'll be okay. Wrong components do happen from time to time. It depends on the manufacturer, but some manufacturers, you can put the wrong component on the a smaller component on the implant and they'll sometimes grab. But it won't be accurately capturing the platform. And so your laboratory will probably use an analog that's smaller and a component that's smaller, and it won't seed at all. And it's hard to figure out why. So what I like to do with implant cases is there's usually a sticker that comes with the implant that your surgeon will have, or if you place it that you would have, has the serial number and the lot number and the part number for the implant. And that way, when you talk to your implant rep, you can say, hey, the impression coping and analog for this. And then that way you're 100% sure you got the right parts. I have a few images of, I see I'm running a little short on time here, so I'll flip through these quickly. All of them are organized this way. These are Nobel active. So on the left, I have a healing abutment, and then I have a scan body, and then I have an open tray and a closed tray. And you can see if you have parts laying around and you're like, is this open tray or closed tray? Open tray have these ridges on them that make it very difficult to pull out the impression. So that's how you can kind of tell an open tray. Closed trays have index marks that are smooth. So, and most systems are color coded. With Nobel, the little tiny ones, the 3 O's are gray, and then you have the narrows that are purple like this. Regulars are yellow, and the wide platforms are blue. And they use a unigrip driver. Straumann has several different components. In the interest of time, again, you got healing abutment, scan body, open tray, closed tray. They use an SCS driver, which is also a star driver, but it's just a little bit bigger than the Nobel one. Make sure you get a nice assortment of drivers. So that way you need a unigrip, an SCS, an 048 hex, an 050 hex. And I would say today you need a Neodent driver, which is it looks like a unigrip that's unique grip, but it's really, really small. So I would say if you have those, you'll be in good shape. This is Straumann's older, the tissue level implant. A lot of times you'll be restoring these with a stock abutment, but you can do a fixture level on the Synopka. It's been around for a long time, but I know a lot of surgeons who say you get a great result with this. The main thing is these can be a good case for guided because they got to be in a perfect position. If they're not, they're difficult to correct for. ZimV has 2 systems. They have their TSV, which you see on the top, and they have their certain on the bottom. So here's the stinky thing. The top ones use an 050 driver, and the bottom ones use an 048 driver. And it's really hard to look at them and tell the difference of 200s. But what happens is if you try to use an 050 and an 048 hole, it just won't quite grab. So if you're feeling that, that's probably what's going on. On the other hand, if you use an 048 and an 050 hole, it'll grab, but then when you start turning, sometimes it'll skip, and then it actually strips out the screw head. So that's really not good. So you want to make sure you have those right instruments. The other thing that's interesting about ZimV is that the second thing here from the left is an encode abutment. And when it came out, it was hard to describe what it is, but today we can say it's a healing abutment that's also a scan body. So if you get a case with one of these, literally all you got to do is scan it the way it is. You don't have to take anything out, don't have to get any more parts, nothing. All right, these are BioHorizons components. One part that I don't have here is there's a new peak impression coping that it snaps in the implant without a screw. So what it is it's a closed tray that it's like an open tray rather than you don't have to unscrew. So it's pretty cool. First time I saw it, I'm like, oh, well, this thing stinks. But then I fit the analog on there, it fit really, really well. So it's a nice way to have closed tray convenience with open tray accuracy. One other thing to keep in mind with these is that if you get a tapered plus implant, the tapered plus implant, the platform is smaller than the body of an implant of the implant. So a 5.7 tapered plus has a 4.6 platform. So in general, when you're working with your laboratory, make sure you let your lab know what the platform is. That's the part we need to know. That's the part that we work with. These use an 050 driver. Dentsply Astra, as you guys know, Dentsply have an awful lot of implants, ankylose, Sive, MIS. The Astra, I think, are their premium line, a little more popular. There's the EV on the top and the TX on the bottom. Two interesting things about the Astra components. The first is that their impression copings have not 6, but 7 index positions. And so sometimes when you're trying to take the impression, you have to turn the thing 360 degrees before it grabs, which can feel kind of weird if you're used to most components that are either 4 or 6 positions. The other thing to keep in mind is that there are EVs and EV profile implants. EV profile implants are entirely different than EVs, so good to know that. So when you're doing an all-on-X case, if your surgeon asks you to take the preoperative records for them, make sure you help them out by getting the video under control, because that's something that you're going to have some expertise with. A lot of times these patients have lost vertical. So when you take your master impressions, you'll want to make sure you capture borders like a denture, because your surgeon may need a denture. And then when you're capturing the bite, you want to make sure you capture in CR and at the correct video. After healing, you'll need to get the master impression. And for these, always use an open tray. Usually have plenty of vertical, plenty of access. Really important to always use an open tray because we need a good fit on these. When you're cutting your holes in your tray, make sure that you don't overly weaken the tray. That's really important. And it can be good to do border molding, even though with some of these cases, we're not going to be using something with borders. We'll just use a screw retainer that sits on the ridge. So, but yeah, other than that, you'll use your standard. I'm going to skip through this for now. This kind of goes over some techniques for finding video. And I just wanted to point out, after you take your impression, the next appointment, what you'll get back is a verification jig and a bite block. You can ask your lab for a screw retained back block like the one that's shown on the left. Makes it a lot easier to do the case. It's not floppy, and the patient starts to get a better sense of what the prosthetic is going to be like. The other thing is a verification jig. And what these are for is, again, we talked about the model has to be exactly the same as the mouth. So your laboratory will take a bunch of temporary cylinders, lute them with a low expansion resin, and check it on the model and make sure that it seats passively. What you'll do in the mouth is you'll take this, go to the mouth, screw in all the screws and then take out all but one and do an x-ray. If it's seating fully, then the mouth and the model are the same and will be good to go to the final restoration. If one of them is off, you can cut on both sides and loop the pieces together with a low expansion resin like GC resin or something like that. But if more than one is off, I'd recommend taking a nice new open tray impression. All right, that's all we have.
So thank you, everybody, for your time. I know you all have to get ready to get on the clinic floor. Looking forward to seeing you all soon in your clinics. Just remember, NDX, myself, Jessica, Tremaine, we're here for you today, tomorrow, and the future. Have a wonderful day, everybody.